Yeah, thank you very much, Andrew. I absolutely hate following on from Graham. It's a great honor to be able to report some of our early work with Delcath chemosaturation, percutaneous hepatic perfusion. This is down as the Southampton experience. I'm not a radiologist, I'm a surgeon, so my job largely with this is sitting in the radiology control room eating donuts, which I've got quite good at, I have to admit. We're doing a right click to move on? Left click, okay. My declarations, I'm sponsored by Delcath for this, but otherwise no financial interest. So ChemoSat has an EU device indication for the percutaneous intraarterial administration of chemotherapeutic agent, melphalan, into the liver with subsequent extracorporeal filtration of the hepatic venous blood, lowering the concentration of the agent in the blood before returning it to the systemic circulation. It's a bit of a mouthful. This came originally from the principle of isolated hepatic perfusion. Not something that's been widely practiced. I don't think anywhere in the UK has really done it, but within the States and occasionally in places in France and Germany, there have been surgeons who historically have isolated the liver by controlling the vena cava, pumping the liver full of very high-dose chemo agent and then filtering it out. It's got some major limitations. It requires laparotomy, it's a one-time only procedure, and if combined with surgery, it becomes quite an invasive, high morbidity, high mortality procedure. So this is an extension of that concept. The chemosaturation technique is percutaneous. It involves placing a twin balloon system up in the inferior vena cava and isolating the liver. And percutaneously, via the hepatic artery, pumping chemo into the liver and filtering it out and returning it via a vena-venous bypass system with a filtration unit. It uses melphalan. It's a drug that's been around for probably 50 years and more, very well understood. It's very toxic to bone marrow systemically, but it's virtually non-toxic to normal hepatocytes, even in extremely high concentration. So it's quite a good agent for use in the liver. You can give a massive hepatic dose, but filter it out and give a very low systemic dose. There are, however, problems. The liver does have other venous circulation other than just the hepatic veins into the IVC. You may be familiar with some of these perfusion defects that you see around the falciform ligament and elsewhere around the liver. And these are in part related to alternative venous drainage of the liver along the falciform and so on. So if you're going to do this procedure, you have to be aware of your vascular anatomy of the liver. So this is the normal arterial anatomy and all the anatomy of the celiac trunk. You also have to be aware of all the many aberrations of normal anatomy. And your radiologist has to deal with these because effectively you have to isolate the normal, proper hepatic artery and ensure that is your only arterial inflow into the liver so that you aren't pumping chemo via any collateral circulation elsewhere. So step one is to do an arteriogram and block off both the gastroduodenal artery and also the right hepatic. In this case, you can see some flow down the falciform vessels there, despite having blocked off the GDA. So it's another patient, GDA and right gastric. And you can see the retrograde flow along the right gastric, along the lesser curve of the stomach into the left gastric, and from there into the circulation. So you block off the GDA, you block off the right gastric, and then you have your isolated arterial supply to the liver, and you're ready to look at PHP. So it needs a big team. This isn't just about an interventional radiologist. In our case, we have two, but predominantly it's Brian Steadman doing them. There's a big emphasis on multidisciplinary assessment beforehand, and Professor Christian Ottensmeyer is a melanoma oncologist, as is Matthew Wheater. You need the pharmacist, you need perfusionists to man the vena-venous bypass, you need a surgeon to eat the donuts, you need The anaesthetic team, who should be anaesthetists who are capable of managing bypass, capable of managing major liver-related procedures, and also have good ICU management skills. And the patient and family need support and the workup from nursing staff. So your IR suite, rather than just being the kind of one or two man show that it would normally be, looks more like a cardiac theatre when you're doing this, with your perfusionists and intensivists and all the other team there. And as you can see from the chest x-ray there, the patients have many, many lines put in. They have Swan-Ganz lines, they have the vena-venous return, they have central venous monitoring. And it is quite a big program setting these up. When we started doing this, as we were the first centre in the UK, we notified NICE, but obviously as there's relatively small amounts of data, this is only a NICE notified procedure rather than approved. And so this is the business end, this twin balloon catheter that sits in the inferior vena cava, one balloon above the hepatic veins and one below, isolating the venous return of the liver. So on this scan, you should be able to see the vertical catheter sitting in the IVC, going up from the right iliac vein. And as you can see there, the tip of that is sat right up high in the right atrium. Below it, you should see just about, there's not a pointer on this, but basically you can see the superselective catheterization of the hepatic artery as well, with the associated coiling of the GDA and right gastric. You then blow the superior balloon up inside the right atrium. So it's got contrast in the balloon there. And then you pull the balloon back into the IVC, giving it this kind of button mushroom type look. When you're happy that that's in position, you then blow up the, hopefully. So I want to move to the next slide. Next slide. No, maybe not. Let's get a slideshow. Okay, so you blow up the lower balloon inside the IVC, and then you do a test run retrogradely filling the IVC through what will be the drainage port and looking for leaks around and about. At the upper end there you can see the middle and right hepatic veins, but also a load of short hepatic veins, and also lower down some retrograde filling of the lumbars. During the procedure itself, there's negative pressure in here as the filtration system is sucking blood out from the IVC between the two balloons. So although there is some filling of the lumbars, unless they're massive, it's not usually an issue. And there are some major effects related to this. On the left, I've just seen an angiogram with some very weedy vessels, and that's because you get intense arterial vasospasm in the hepatic artery during the procedure. The hepatic artery doesn't like being pumped full of melphalan for some reason. And that's actually quite a problem, so you sometimes need to give GTN intra-arterially to enable the flow of the chemo agent. And the patient systemically doesn't enjoy being on this filter. The pressure often crashes down, the systolic down to 30 to 50 when you're on the filter. So it's a major physiological insult, and your anaesthetist needs to be on the ball with syringes full of various vasopressors. But it's not quite as hairy as it sounds, and it is entirely manageable. The patients that we do it in, at the moment we're only doing it in ocular melanoma patients, and that's based on an initial study from the States, a phase 3 trial reported at ASCO in 2010, 93 patients in a crossover study, and there was basically substantial improvement in hepatic progression-free survival, and again, a significant overall survival benefit based on an intention to treat principle. Somewhat muddied waters by the crossover nature of the study. So when we were setting this up, we went for our local new procedures approval, demonstrating that there was safety data, clinical effectiveness data, clear indications, which initially we've limited to ocular melanoma. Cost effectiveness is harder to prove with the data that's out there, but we are working on that. And a program of training, mentoring, and audit of our results before establishing whether this would have a long-term role in the future. Forgive me, but I always have to show a laparoscopic liver resection somewhere, and this is a melanoma patient. So where are we using it? We're using it in ocular melanoma metastases, principally small volume diffuse bilobar disease. That was our initial indication. Less than 50% parenchymal replacement, normal liver function, no extrahepatic disease, and no other surgical or ablative option. And previous surgery or other treatments have been considered acceptable. So, why ocular melanoma? Well, it's extremely resistant to conventional systemic treatment. The series of scans are on a patient referred to us, and over the course of 3 months on dacarbazine, this patient progressed from a relatively small operable or ablatable metastasis to a very large central lesion. It's very difficult to think of any useful way of managing, as it had multiple satellites around it. So ocular melanoma is it's a bad disease. Of the patients who develop metastases, 95% of them plus will get liver metastases, and in the majority of those it'll be liver-only disease. So again, it's good for the model of PHP. So our inclusion criteria: patients had to be performance status 0 or 1 prior to treatment, with normal liver function, adequate hematological and renal function, not pregnant, and excluded anybody with an active bacterial infection, allergic reactions to any of the agents used, or hypersensitivity, and patients with bleeding disorders, any evidence of intracranial disease, or anything that would put the patient at risk for bleeding when they're fully anticoagulated on bypass. Then within 4 weeks of the procedure, they get re-examined. Full set of imaging studies, including a whole-body PET, MRI or CT of the brain, baseline lab workup, cardiac and respiratory screening as appropriate, depending on the patient's fitness level, laparoscopy for patients where we're concerned they might be approaching 50% liver replacement with tumor, and hormonal suppression of menstruation due to the extreme anticoagulation used, and allopurinol for potential tumor lysis syndrome. So post-procedural in-hospital care, all go to intensive care for 12 hours, monitoring for reaction to the agents and looking for bleeding, and then step down or discharge home directly from ICU. So we've only treated 4 patients so far, although we've had quite a lot of publicity out of it all. We've lined 5 treatments up within our 4 patients. They've all been ocular melanoma patients with between 10 and 50% parenchymal replacement. 3 of the 4 had had previous treatments. 1 patient had had 2 liver resections, and 2 patients had had chemotherapy, one with dacarbazine, which unfortunately has virtually no effect in ocular melanoma despite being the standard of care, and one with ipilimumab, which is one of the new biological agents, which is remarkably effective in some patients with melanoma now. So, outcome. First patient, we abandoned the procedure as we couldn't get a good venous seal. This patient had right hepatectomy before and had further tumor deposits close to the hepatic veins causing distortion, and we just couldn't get a good seal, so we didn't proceed. All the other treatments have been remarkably straightforward. So the first patient who got no treatment was dead within 2 months of disease progression. He had managed to survive about 18 months since the initial diagnosis of metastatic disease. Second patient died of extrahepatic recurrence with stable liver metastases at 9 months. She had also survived over 2 years in total from her initial presentation. Third patient is stable, alive, 10 months out, and doing well. The fourth patient has convincing regression of metastases on her first scan. So this is patient 3 on his initial presentation scan. So he had approximately 20 sub-centimeter metastases. He'd been laparoscoped as well, and also had miliary disease smaller than radiologically visible. And that's his scan 10 months later. So virtually no change, stable disease, 2 treatments. Now, if you compare that with the typical set of scans that you saw earlier, where you have a patient that goes from a 2.5 centimeter deposit to a 8 to 10 centimeter deposit within a few months. Now, okay, different patients, but one of the things about ocular melanoma metastases is that they just are uniformly predictable. They grow at an incredible rate of knots, and you do not see patients with stable disease without some form of treatment. So where next with ocular melanoma? We're looking at considering patients like this. So a very large left-sided metastasis, looks worse because of the local vascular involvement. But what about staged left hepatectomy and regional therapy with Delcath plus or minus an immunological agent? One of the reasons we got an interest in ocular melanoma in the UK is this lady here, who's Leslie Kirkpatrick, who's a GP from Doncaster. Very happy to have her details splashed around the world. Diagnosed with ocular melanoma in 2007, got liver mets in 2009, operated on by Pete Lodge in Leeds, and had 3 metastases removed then, further liver resection in 2010, went on to ipilimumab, developed new liver lesions, ended up with a lot of liver lesions, got CERT, got microwave ablation after a stunning response to the combination of IPI and CERT, gamma knife recently for a 3mm dural lesion, but that's her only disease. So there's a small number of patients that we're now identifying who go onto biological agents and have an aggressive approach, who go from this pattern of inevitable, inexorable progression of disease into a manageable state where they live in symbiosis. Now, I'm sure it's the biologicals that are having an immense impact, but combined with the surgery and combined with regional therapies, I think there's an awful lot more that we can offer for these patients. So multimodality treatment, which has been described in both the talks so far, this kind of principle of using biologicals and immunologicals to change the way the disease is working, gives us a whole new dimension, and they're not to be used in isolation. It's a combination of local treatments, of ablation and surgery, regional treatments, a perfusional therapy. If the liver is your dominant organ of disease, and you can knock it back, if you can deal with the micrometastases as well as the surgically visible disease, add in the systemic therapy, change the biological behavior of this disease, then there's an awful lot that I think that the future holds. And hopefully in years to come, we'll have some nice little curves for ocular melanoma, or rather like Graham's had for colorectal disease. So the summary of our experience, I think it is a difficult procedure. It needs careful evaluation of the anatomy, but you can achieve incredibly high concentrations of chemo within the liver, up to 80 times that achieved systemically. It's a technically difficult procedure. It requires a lot of resource, and really it needs ultimately better funding. But as I say, there is quite a lot of work looking at coding and so on to see what can be done about that. We've demonstrated it can be done safely in the UK in the small numbers that we've taken on so far, and I think it needs to be cautiously introduced further. It's really finding its place. We've picked really one of the least promising tumor types that you could imagine, ocular melanoma liver metastases. We haven't changed the world, we haven't cured hundreds of patients, but we have made a number of them live surprisingly long. So we can see now that it's starting to work in ocular melanoma, and where next really is the question. Thank you.